Welcome everyone, and I would like to introduce you my PhD topic, which is insights into mechanical ventilation. Prolonged duration of ventilation can lead to severe lung injuries in up to 25% of the cases. Automated modes have been developed to reduce the burden of ventilation. However, its clinical effectiveness still needs to be proved. In this systematic review and meta-analysis, we found that automated modes have a tendency to reduce the duration of invasive ventilation by 1 day. However, we need further research to find the best cohort who benefits the most, and also to improve our current technology more. In order to do so, policymakers should support this research. My name is Réka Petra Tóth. I'm a PhD student here at Semmelweis University, and I envision a future where everyone has access to advanced medical technology, no matter who they are. And my mission is to improve the current technology. In order to do so, we launched 2 projects this year. One is a systematic review and meta-analysis, and the second one is a retrospective observational study. So my first project title is Comparing the Effectiveness and Safety of Adaptive versus Conventional Modes in Invasively Ventilated Patients. Nearly half of the ICU patients require mechanical ventilation, which is far from having no risks, such as ventilator-associated lung injuries or pneumonia. We are using manually adjustable ventilator, which means that adjustments are only made when the physician has time to do so. This practice may lead to an elongated duration of ventilation and elevated complication rates. However, there are new systems called closed-loop systems, or in other names, automated modes. They could tailor the ventilator to the patient's needs in real time by analyzing it within one breath or breath to breath. Even though this technology seems to perform better than the conventional modes, we are still lacking of evidence how effectively or how it truly impacts mechanically ventilated patients. So in order to investigate it, we have our clinical question, which is, are adaptive modes more effective and safer than conventional modes? We used the PICO framework. We investigated on invasively ventilated adult patients. We compared adaptive modes to conventional modes, and our primary outcome was duration of ventilation. And we hypothesized that adaptive modes significantly reduce the duration of invasive ventilation compared to conventional modes. Oops. So, we started our research with 13,000 articles, and at the end of the process, we ended up with 55 eligible articles for data extraction. Here you can see our progress throughout the year. We are just 1.5 steps away from starting to write a manuscript. So first, I would like to show our outcomes, or our main outcomes. The duration of invasive ventilation and duration of ventilation are quite similar. Duration of both of them starts at the intubation. However, duration of invasive ventilation ends with the successful extubation, while duration of ventilation also includes the accessory non-invasive ventilation as well, and ends with the discharge. We have 2 other continuous outcomes: duration of weaning and extubation time. They are basically the same, except they are used for different patient population. Duration of weaning is used in general ICU patients, while extubation time is used in postoperative patients. They both start at the eligibility for weaning and ends with the successful extubation. It's defined as no reintubation needed after the procedure within 2 days. So let me introduce you our main results. As I mentioned, the less time the patient spends on mechanical ventilators, the less likely it will develop any complications. So basically, the duration of ventilation ranges between 2 days to 1 week on average. So it means that even 1 day reduction is clinically relevant and important. We used the subgroup analysis to check, because adaptive modes have different methods, and we wanted to check whether is there any difference between the different methods. So in our results, we found that in regard of adaptive support ventilation, we found a statistical significance and 1.5 day reduction. However, our pooled estimate wasn't clinically significant. Our next outcome was to the duration of invasive ventilation, where as we checked the adaptive support ventilation, we didn't reach any mathematical significance. However, here our pooled estimate was mathematically significant and clinically relevant. This is reduced by 16 hours. These results suggest us that adaptive modes have a tendency to shorten the duration of ventilation. Let me show you another outcome, which is ventilator-free days. It defines as from intubation to until 28 days, how many days patients spend on a mechanical ventilator alive, which is basically the combination of mortality and total duration of ventilation. Here you can see that our pooled estimate wasn't clinically significant. However, we used a subgroup analysis that was based on etiology. And as you can see, that in a mixed ICU population, we ended up with a clinically less significant results with 4 days more in adaptive when we're using adaptive modes, which has a message to us that once, it can accelerate recovery from respiratory failure, and second, it does matter which patient population we use our modes on, or our technology on. So let me show you quickly our other results. So we have duration of weaning extubation time. Both were not significantly nor mathematically significant. And the same could be said about weaning success and extubation success as well. So our methodology, we use a rigorous methodology. We included a high number of studies, and we used transparent reporting for our outcomes. However, we had our limitations. We included observational studies as well. We worked with a high heterogeneity in all of our analysis. And for different articles, there were different clarifications for the outcomes. But we could conclude that there is a tendency for shorter duration of ventilation when we use adaptive modes. And we could conclude a non-inferiority to the conventional one. Our implication for practice is that automated modes could be used and could be a useful tool in managing general ICU patients. However, we have a suggestion for future research, such as we need to find the best patient population for targeted usage, and also we should improve this technology further. So let me introduce our next project, which is model-based optimization of mechanical ventilation, which is a retrospective observational study. As I mentioned, we are ventilating a huge number of patients with a high rate of complications. We do know that by optimizing ventilator parameters, we can improve outcomes. We already do that with our ventilators, which uses an oversimplified lung models. We would like to create another mathematical model in order to improve this current technology. But as a first step, we need to check whether our model is accurate enough to be moved further to optimization. I would like to sum up our progress. We launched 2 projects. One is targeting to compare a current technology to a conventional one, and my second project aims to improve this current technology. Let me close my presentation with a quote from one of my favorite books. The ultimate answer to life, the universe, and everything is fortitude, which is important, and bear it in mind that without a great question, you cannot understand the data. Thank you for your attention.
I'd like to ask, are there any countries that already use these adaptive modes over the conventional ones, or is this just something that's being experimented with?
So you would like to ask about the automated modes, whether they are in use in generally. If I know correctly, it's not part of standard medical care, but in different countries, in different hospitals, there are tendency to trying to implement it in daily practice.
Okay, so there's enough evidence as of now to...
Yeah.
Okay, thank you.
You mentioned that if you use these adaptive modes in mixed population, that's fine. But what about the COPD patients? Because it seems that it's too harm, or I don't know.
Well, let me get back there.
Regarding your first, this one.
Yeah, this picture is a bit misleading, this first plot, because we only included 2 COPD studies.
In the mix.
Yeah, so we cannot conclude any out of it that is statistically backed up.
All right. Super. Thanks. So we should use these adaptive modes in COPD patient as well?
I wouldn't say that right now. The main message is here that we would like to study it, which patient population benefits the most out of it. And it's not just about automated modes, that which mode should be used in which situation as well.
Thanks.
I think an important add-on question, maybe it will help everything clarify a little bit, is when we are talking about ventilator-free days, are we talking about freedom from invasive ventilation or freedom from either invasive or non-invasive ventilation?
If I know correctly, is either the both, so it's from the both.
Because COPD patients will spend way more time on non-invasive ventilation.
Thank you very much for